everyone. Good evening, sir. Good evening to all my fellow colleagues out there. So, with the renovascular diseases, I will be sharing many topics with you today. So, the first topic is renal artery aneurysm. Most of the times, these are incidentally detected. The incidence is 0.7% of all the CT iotograms which are done occasionally for other intra-abdominal pathologies when they have not revealed anything in particular. And we see bilateral RAAs in 10% of cases. Now, going into the types of renal artery aneurysms, there are true, false, and dissecting types. In true, there are secular and fusiform. Fusiform is said when it is complete circumferential dilatation. In secular, there is just a partial dilatation which is seen. And then they can be extraparenchymal, outside the renal parenchyma, or intraparenchymal. And as usual, the most common ones are extraparenchymal, which are 90%, and rarely less than 10% cases are intraparenchymal. So going to the true aneurysms, which are 90% extraparenchymal, the peak incidence is seen in 40 to 60 years of age group. They can be because of two common problems like either atherosclerosis or congenital. The congenital variety or the congenital etiology is the most common one, in which what we see is that the medial degeneration is seen with weakness of elastic lamina, which leads to formation of the true aneurysm. In atherosclerosis, as we know, it causes intimal defect because of smooth muscle proliferation in the intima. And in atherosclerosis, because it's a generalized disease, most commonly we can see multiple lesions in this case. So we can see multiple aneurysms, multiple true aneurysms in a case of atherosclerosis. Now going to the typical location, but before that, I would like to share you the anatomy of the renal artery. So the renal artery, the main renal artery, which gets arise from the aorta at the level of L1 and L2. Initially, it gets divided into two divisions, which is anterior division and the posterior division. The anterior division, goes across in front of the renal pelvis and then divides into four segmental branches, in which there are superior segmental, anterior superior, anterior inferior, and inferior segmental. The posterior division runs behind the pelvis in the posterior aspect of the kidney, and it gives or it continues only as posterior segmental arteries. Further, these arteries, they go across the segmental arteries, they go across the renal pyramid, and they're known as arcuate arteries. But mind it that they still don't cause any, there's still not any anastomosis which is there in between them. They just run across the renal pyramid. Further, they give the branches which are known as interlobar branches and then interlobular arteries, which have afferent glomerular arterioles, which are actually where the anastomosis takes place in between the two. And hence it goes around the periphery of the renal parenchyma, and hence it supplies the renal cortex and medulla in general incomplete. So the most common place, the typical location of true aneurysm is primary or secondary artery bifurcations. That is when the anterior divisions of the segmental arteries start. The true renal artery aneurysms are 75% of cases, they are secular, and they are seen at the main renal artery bifurcation, in which it is being divided into anterior or posterior segmental branches. Now for the fusiform dilatation, that is generalized dilatation, what happens is in a case of atherosclerosis or fibromuscular dysplasia, there is renal artery stenosis, and distal to this renal artery stenosis, we see a post-stenotic dilatation, which leads to formation of fusiform aneurysms. Now, I would just like to mention what happens when there is an arterial stenosis. Not in a case of mild or severe, there has to be a moderate arterial stenosis, in which what we say that more than 50% of arterial stenosis is there, in which there is the peak systolic volume is twice the normal. We see audible bruit and palpable thrill in these cases. Because of this, there are eddies, currents which are created. Hence, there is turbulence which is there. There is stasis of blood. There is more lateral pressure. There is cavitation. And there is abnormal shear stresses which is there. These are the proposed mechanisms for the resultant post-stenotic dilatation. Though they say that there can be a vessel wall ischemia distal to the stenosis, which leads to post-stenotic dilatation due to the weakening of the wall. And this in general is known as Venturi phenomenon. And this results into aneurysm distal to the renal artery stenosis. Further, the post-stenotic dilatation, when there is loss of pressure, there is stasis, and hence there can be thrombosis, and distally embolus emboli can be there, which can further deteriorate the condition. Now, coming to the fibromuscular dysplasia and renal artery aneurysm, the correlation. Usually we see microaneurysms in these cases. They are few millimeter in diameter, which is seen in 9.2% of FMDs. What we see is medial fibroplasia. Hence, there are multiple stenosis and post-stenotic dilatations, which are seen in these cases. Typical angiographic appearance because of multiple stenosis and stenotic dilatation is strings of beads appearance in fibromuscular dysplasia. Now coming to the second variety, which is false or pseudoaneurysm. Commonly, it is seen in a case of trauma or iatrogenic injuries. In trauma, it is blunt or penetrating trauma to the abdomen. And iatrogenic cases, it is renal artery catheterization or nephrectomies which are done, which leads to pseudoaneurysm formations. Third, there can be dissections. Spontaneous dissection in a renal artery is rare per se. Primary dissections, which leads to pseudoaneurysms, is commonly seen in renal artery than any peripheral artery. Now, point to the mechanism again. The renal artery, when there is atherosclerosis, which is there is intimal defect. Because of this intimal defect, there is weakening, and hence there can be spontaneous renal artery dissection, which leads to aneurysm formation. Now, this is the mechanism related to the atherosclerosis. The other two diseases like fibromuscular dysplasia, in which the renal artery involvement is seen as 0.5 to 9%. And in trauma, which is blunt or iatrogenic, it is seen that the blunt trauma is commonly seen on the men and on the right side. Then the next variety is, which is a rare variety of true aneurysm. Like I told, more than 90% are extraparenchymal. Now the less than 10% variety is the intrarenal or intraparenchymal aneurysms. These are most commonly congenital and multiple. Being congenital, they are commonly associated with collagen vascular disorders or AV malformations per se, and can be post-traumatic also. They are also seen in polyarteritis nodosa. It is a collagen vascular disorder in which there is renal cortex involvement, which is seen. Now coming to the clinical manifestations of renal artery aneurysm. More commonly, they are asymptomatic and they are found on imaging, as I told, incidentally found for an intra-abdominal pathology, which was worked up for. The other dreaded complications, or when it becomes symptomatic, is the most dreaded one is rupture. In a case of rupture, what we see, the presentation is of an acute abdomen. There is distension and there is hypotension, which is there. The second is hypertension. Third is pain, which can be because of the rupture itself or the dissection, and hematuria. Now, something which is very important to know is a stable non-inflammatory renal artery aneurysm is painless. So it should never be attributed to chronic abdominal pain. So in a case when there is in a patient, there is chronic abdominal pain and he is being worked up, and on imaging, we find out that there is a stable non-inflammatory renal artery aneurysm, then we have to make sure that it is not the renal artery aneurysm which should be attributed for this problem. They are just incidentally detected and the other things should be worked up and the cause of pain should be ruled out. Now going to hypertension, basically it's a renovascular hypertension which is there, which is usually seen because of multiple mechanisms. Like there is distal embolization with segmental hypoperfusion. There is segmental hypoperfusion because of the embolus, the distally there is no blood flow, there is decrease in the glomerular filtration pressure, which leads to activation of renin-angiotensin mechanism, and hence because of that there is renovascular hypertension. Also because of the fluid retention. Hypertension is commonly not seen. It is basically uncommon in a case of secular or intrarenal aneurysms. So they're commonly seen in true variety, in which more commonly in the fusiform variety, and that too extra parenchymal involvement, which in general is more common. Now, one more thing which we should know is that renal artery aneurysms per se, they don't directly cause hypertension, though they are associated with hypertension in 80% cases, but they are not directly associated. What happens in a renal artery aneurysm is if there is an associated stenosis, which leads to renal artery aneurysm, as I told, or there is compression of the adjacent artery because of the aneurysmal dilatation, there is pressure effect in this compression, or there is luminal stenosis due to extensive thrombus. Either the aneurysm per se has thrombosed, or there are distal emboli because of the aneurysm, which leads to the mechanism of activation of renal angiotensin mechanism, and then there is hypertension. But it is not directly because of cannot be directly attributed to renal artery aneurysms. This will help us in further when we discuss the management. Now, in case when there is a dissection, as I told, in the cases of atherosclerosis, there are spontaneous dissections which are possible, leading to renal artery aneurysm because of the weakening of the wall. There is severe flank pain, hematuria, and acute onset hypertension. Though dissections are mostly asymptomatic, a person being worked up for these symptoms is sometimes found to have dissection which has resulted into renal artery aneurysm. Now, after the clinical manifestations, we go, when do we need to intervene? And obviously, in a case of rupture, there's an emergency, though the chances of rupture are less than 3% only. But the most common indication in asymptomatic renal artery aneurysms is prevention of rupture. So now, the indication of intervention is when it is more than 3 centimeters in men or women older than childbearing age group, or any renal artery aneurysm in a woman of women of childbearing age, namely more than 1.5 times the diameter of normal adjacent artery. So in men and in women older than childbearing age group, it has to be more than 3 centimeter. Initially, it was supposed to be done. It was proposed to intervene when it is more than 2 centimeter, but it was found to be very much aggressive as the studies were done. Then hypertension. The only indication of intervention in a case of renovascular hypertension in presence of artery aneurysm is failure of medical management, because I told you initially that literature says that more than 80% of times it is not directly associated with it. So we should not be intervening in this case. So initially there has to be a medical management, or a nephrologist should see it, and until unless there is a failure of medical management, which in general is told to be that the hypertension is not being controlled even after 3 or more antihypertensives have been used, then we have to intervene. Dissection, mostly asymptomatic, and in a case of dissection, if there is a controlled hypertension, there is no need of intervention. But if there is acute dissection which is symptomatic, then it is emergency and needs to be managed on emergent basis. Now, why all the women of childbearing age group need to be treated is actually because of pregnancy. Because in case of pregnancy, there is hyperdynamic state, there is increased blood volume, increased cardiac output. It is also because of the hormonal influences, and also because of the gravid uterus out there, there is increased intra-abdominal pressure. Hence, all these three major factors increase the risk of rupture, to that extent that the maternal mortality rate after this rupture is 55%, and fetal death associated is 85%. Hence, hence it has to be aggressively treated, and the intervention is deemed necessary in a case when the woman is pregnant and is found to have renal artery aneurysms, or in general women of childbearing age groups. The approach can be surgical or endovascular in all these cases. So now coming to the treatment. So if it has already ruptured, if the patient is stable, we can proceed with endovascular procedures. If the patient is unstable, then we have to intervene immediately, and open surgeries are done. Because of the hematoma surrounding the kidney, the approach is usually a midline approach, and we have to do a supraceliac or a suprarenal control. Just go to that room. Sorry, midline and supraceliac control has to be done. So now, if the bleeding is controlled and hemodynamically stability is achieved intraoperatively, then we can, and if there can be a quick, straightforward bypass which is feasible, then yes, we can go for reconstruction of the renal artery. But if there is no to any of these things, that the bleeding is not controlled, the patient is hemodynamically unstable, and a quick straightforward bypass is not possible, that we have to go for a vein bypass, or we have to go for other ways of bypassing the aneurysm rupture, then nephrectomy is the only way out. But we have to make sure that when we proceed for nephrectomies in such cases, there has to be that intact contralateral kidney is supposed to be there. Otherwise, the patient will be deemed for dialysis in his future. But even in such scenarios, saving life is more important. So when do we say that there are poor prognosis in these cases? If there is prolonged ischemia due to any of the renal, either due to rupture or any of the renal artery problems or pathologies, if the patient is unstable because of the rupture, or if the renal artery aneurysm is extending into the renal parenchyma, that is, it is an intraparenchymal disease, or it is involving the distal branches. As I told you, the true aneurysms are involving only the primary and the secondary divisions, that up to the segmental branches, that is external, that is extrapyramidal, extraparenchymal. But once it goes into the parenchyma, or it is involving the distal branches, then it is poor prognosis, because it is very difficult to reconstruct these vessels. And renal arteries per se are end arteries. So any of the pathologies associated with these renal arteries, there is ischemia which is there, and we have very less ischemic warm ischemia time in these cases. That is why we have to proceed for nephrectomy. But again, repeating, if the bleeding is controlled, patient is hemodynamically stable, and it's a quick, straightforward bypass is feasible, all these three scenarios, we can go for a reconstruction. Now, in case when we are proceeding for elective repair, on the left side, left retroperitoneal or midline transperitoneal incisions can be given. On the right side, midline transperitoneal incisions are preferred. In a case of secular aneurysm, only aneurysmography with primary repair, which can be using primary repair can be done plus with a patch plasty. Renal artery reconstruction when it is required, which is commonly required for a fusiform aneurysm when complete circumferential involvement is there. In that case, end to side or side to side anastomosis of a main renal artery with distal small branches is there. In a case of side to side anastomosis, what we do is that two of distal small branches are anastomosed side to side to form a major caliber, so that it can be finally anastomosed with the main renal artery to maintain the continuity of the blood flow. Because of the distal branches being involved, we require branched autologous grafts for reconstructions. And the commonly used one are internal iliac artery, in which there are branches also there. So we can pick up that segment, we can sacrifice one of the internal iliac arteries and use it. Otherwise, a saphenous vein can be used with its tributaries preserved in these cases. Sometimes when all these procedures are being done, there can be a bend surgery which is indicated, in which case basically we do a nephrectomy, we take out the kidney, we perfuse the renal kidney by Collins solution, we do an extracorporeal operation. Basically we repair it primarily outside the body after freezing it or using renal perfusion, and then we do an auto transplantation, which is commonly done at the level of internal iliacs or external iliacs in the pelvic fossa. Another way of performing all these surgeries nowadays is laparoscopic or robot assisted. Otherwise, what we can do in a case of emergency is we proceed with diagnostic laparoscopy, and then we can further decide what to do. It helps us in marking our incision and proceeding. Now coming to endovascular procedures, it is ideal in these scenarios only when the main renal arteries are involved. We do a shunt graft exclusion, or we can do a transcatheter embolization, in which we can use either non-detachable microcoils or Buglemoll's detachable microcoils, or even liquid embolization things can be used like ethylene vinyl alcohol or glues. So this is the management and in general about renal artery aneurysm. Second topic is renal AVMs, arterial venous malformations or arterial venous fistulas. So true congenital AVMs is what we begin with. The incidence is it's very rare, 0.04% cases, commonly seen on the right more than left, and usually single. And typically on angiography, which we see in any AVMs, any arteriovenous malformation, we see large coils of dilated vessels. Since it is an arteriovenous malformation, there is a AV shunting which is happening. So when we do a angiography, whenever dye is given, there is early filling of veins. That is, there is early blush. So we see filling up of IVC even in the arterial phases. And more the degree of AV shunting, earlier is the blush, which is noted in angiography, which is the diagnostic test. It commonly involves renal medulla, and it is commonly symptomatic only in pregnancies. As I told you, there is hyperdynamic circulation which is there. So all these conditions, all the AV shunting gets symptomatic in case of pregnancy because of the hyperdynamic circulations. Second is acquired, which are known as AV fistulas. Commonly they are traumatic, which is most common acquired AVF. More than 70% of renal AVFs are traumatic, in which most common cause is percutaneous renal biopsy. With the rise in interventions by the nephrologist, we see more such cases, but most of the renal AVFs which are secondary to iatrogenic injury because of the renal biopsy which is performed percutaneously, they are self-limiting, or they become automatically closed by the end of 1 year. Though even in such scenarios, they are supposed to be closely visualized, and then only intervention is required. Second is nephrectomy, in which when we do a mask ligature, artery and vein together, the artery pulse is pulsatile and it erodes into the vein, and there can be an AV shunting which can take place, resulting into the AV fistula. Interventions like angioplasty or nephrostomies, and in a case of trauma, in which it can be blunt or penetrating. So these are causes of traumatic AVF. Now there's a rare entity in which there's a spontaneous AVF. So for a spontaneous AVF, what has to happen is that the artery needs to be diseased. So it can be congenitally diseased because of the fibromuscular dysplasia or a dysplastic artery, or is already an aneurysmally dilated renal artery, which erodes into the neighboring vein, can be because of the compression or can be because of the pulsatile nature which erodes into the vein, leading into an AV fistula formation. So as I told, it is seen in fibromuscular dysplasia. Renal malignancy, typically renal cell carcinoma, RCC, the hallmark of RCC is presence of multiple AV fistulas in it. So presentation, like all the renovascular diseases which I have mentioned today, it is asymptomatic majority cases, but the most common symptom of a congenital AVM is hematuria. Why this happens is because of the subepithelial varices, because of the high flow, it erodes into the transitional epithelium, and hence it goes into the collecting system. Transitional epithelium is the only boundary between the two, and hence erodes into it and causes hematuria. In rare cases, it can be massive hematuria, but commonly it is minor or microscopic hematuria which is present. Now, this was the most common symptom in a congenital AVM, but then most common symptom of acquired AV fistulas or AVMs is hypertension, When there is shunting of blood from artery to vein, there is an arterial steal. So there is decreased glomerular filtration pressure distally. This mechanism is similar when there is a renal artery stenosis or there is an embolus. That distally the blood pressure, there is an arterial steal which is happening. Because of the decrease in glomerular filtration pressure distally, the renin-mediated hypertension, renin mechanism gets activated, and there is renin-mediated hypertension, which is seen. There can be intermittent perilumbar pain or renal colic, intermittent, which can be there rarely. As associated with all the AV fistulas, high output cardiac failure can be there, and the patient usually presents with tachycardia, palpitations, dyspnea. And on further evaluation, on clinical examination, we see a palpable thrill in the flank, continuous abdominal bruit which is present on the either side of the umbilicus, and we can see on an echo or chest X-ray that there is cardiomegaly, typically left ventricular hypertrophy. And rarely it can rupture, and as in case of any renal arterial rupture, it leads into an emergency. The patient presents with acute abdomen emergency. Now, how do we diagnose all these cases? Usually they are filling defects which are seen in excretory urography because of the distal arterial steal. Now, the most common the diagnostic test which is being performed is CT, contrast CT, AVF and AVMs and RCCs. All these three cases, there is in general AV shunting which is seen. So with a contrast, there is early filling of vein, early filling of contrast in the IVC in the arterial phase itself. But then it is very difficult to differentiate on a CT that whether the cause is a congenital AV malformation or an acquired AV fistula, or the cause is a renal cell carcinoma, in which the hallmark is there are multiple AVFs. But then where we can see is that there's a mass which is seen in RCCs along with it to differentiate between AVF and AVN or an RCC per se. Though these are the tests which are done, CT is the person is symptomatic, patient is being evaluated for any other intra-abdominal pathology. Color duplex is ideal for screening. What we see is there is increased peak systolic velocity, there is increased end diastolic flow velocity, and there is a decreased resistive index RI, which is seen. These are the three typical features associated with color duplex of an AV malformation or AV fistula. Now going to the treatment, in general, asymptomatic, which are majority of the AV malformations, we have to observe them for the development of hypertension, hematuria, or a high output cardiac failure. We cannot just leave them. They have to be observed for all these symptoms and need to be educated for all these possibilities. Per se, when they are symptomatic, surgery is required, and usually because they are involving the distal arteries, they end up into partial or total nephrectomies if we are going for an open surgery. And because of this, there is loss of functional renal mass which is permanent, and there is more morbidity associated with such open surgical procedures. So that is why the treatment of choice for a symptomatic AV malformation right now is endovascular, in which we can do a percutaneous arterial embolization because they are end arteries. So whenever we do an arterial embolization, the major problem is that they can go into the veins and hence go into the lungs or into the systemic circulation and cause non-targeted embolization. But in a case of end arteries, we are performing these surgeries majorly in a safe scenario. So if the an AV malformation is small, we can use glues like endocrines, or we can use macroparticles like we can use 500 to 700 or 700 to 900 embosphere particles. And if the AV fistulas are large, then we can do coils, or we can do ballooning and fixation of all these things. Detachable balloons are there which can go into the AV fistulas, and hence they can exclude the AV fistulas or AV malformations from there. In a scenario when they are very large, we have two procedures which can be done endovascularly. We can perform a covered stent, so we are basically excluding the AV fistula, or we can do a stage procedure in which initially we can do coiling, and ballooning of these cases. And then later on, what we need to do is that we, in the second sitting, we can go for glues or macroparticle or further coiling. So these are I would like to share two images, which a case of renal artery aneurysm. As we typically see, the location is the primary or secondary segmental branching, the secondary branching. In this case, the main renal artery, there is a secondary, there's a segmental artery which is there, and then through the segmental artery, there's a renal artery aneurysm. So we have taken a run by placing a coaxial microcatheter system in which there, because of the availability of microcatheters and low profiles of these catheters, we can reach the distal vessels easily. And hence, when we performed an angiogram by selectively cannulating the distal vessel, we could actually figure out the renal artery aneurysm from there. And hence, what we did, we did a stent assisted coiling in this case. So as I zoom in for you, there is a stunt which is placed, which you can see there is spiral which is present. This is a stunt which is there. This is not particularly a flow diverter stunt, but it has a capacity of flow diversion that it will, as the blood comes into it, it will make sure that it goes in distally. And we, by placing the stunt, we selectively cannulated the the aneurysm, and we coiled it with microcoils. Multiple microcoils were used. And after this, when we have performed the renal angiogram through the main renal artery, as you can say, there is no blush seen in the renal artery in the aneurysm, but there is distal flows. In this case, we were highly successful that there was no loss of renal function, or there was no distal embolus, and there was no non-targeted embolization in this case. So now my next topic is acute renal ischemia. From the renal artery aneurysms to AV malformations, now I'm going to acute renal ischemias. As I mentioned earlier, renal arteries are end arteries. So any acute ischemia in these cases is it progresses rapidly. Rapid progression is seen, and hence we end up having loss of renal functions, which is irreplaceable, irretrievable. Now, in general, quickly, the causes of acute renal ischemia, it can be a renal artery embolism, renal artery thrombosis, trauma, iatrogenic injury, or a renal vein thrombosis when there's a vein involved. For an arterial embolism, commonly in clinical practice, what we see is there has to be a source of emboli. Emboli are distally, the source is distally placed, and embolus comes and causes a renal artery embolism, in which chronic atrial fibrillation is one of the causes. Valvular heart disease is one of the common diseases associated. So for both these three, and then aortic plaque, paradoxical embolism in setting of patent foramen ovale, in which there is direct shunting from right to left side, and there is cardiac tumor presence. Because of the cardiac tumor, there is a mass out there on which there can be a thrombus or an embolus which can form, and then it can distal thromboembolism can occur. For all these 5 pathologies which we have discussed, a 2D echo is something which we need to work up for to find out the cause of embolism, which is more important in these cases. Then renal artery thrombosis. In these cases, what we see is that the pathology is per se in the renal artery. So atherosclerotic diseases and disease, which can be secondary to FMD, secondary to trauma, secondary to renal artery stenosis, dissection, which is secondary to atherosclerosis or trauma, and it can be aortic dissection or a renal artery primary dissection. Fibromuscular dysplasia. Rarely it can be an arteritis, Takayasu's arteritis. There can be a stunt which was placed for either an AV malformation or for renal artery aneurysm, which can get thrombosed. Or there was an hypocoagulable state which led to renal artery thrombosis. Trauma can per se cause any trauma can lead to renal artery ischemia. It can be a complete injury to transection of the artery, or there can be, because of the trauma, there can be an localized thrombosis. Iatrogenic injury can be either because of direct or it can be an embolization which can occur from a distance when we are basically performing some interventions in the aorta or renal artery per se, or there can be an ostial occlusion by aortic endograft when the renal arteries get covered when we are doing an aortic endovascular repairs in a case of aneurysms or dissections. And then coming to the renal vein thrombosis, per se, the common causes are hypocoagulation states, which is pregnancy, use of oral contraceptive pills. Mechanical obstruction can be there because of the pelvic mass or intra-abdominal mass compressing and hence and obstructing the outflow vein. And in malignancies, because malignancy per se is a hypocoagulable state. Now, what happens in a renal ischemia? When there is a renal ischemic injury because of the end arteries, there is glomerular collapse because the glomerulus is not supplied, and there is tubular necrosis. And this leads to decreased glomerular filtration, and there is loss of tubular function. Commonly, there can be a reperfusion injury also associated with a renal ischemic injury when there's a renal ischemic injury in the picture. Because of the increased cytokine secretion, there is leukocyte influx also, and there is increased nitric oxide and reactive oxygen species, which is per se because of any reperfusion injury which can there. But in kidneys, because of the end arteries, the reperfusion injuries are more severe and dreadful. Now, what is more important is that what is the duration of ischemia? Because if it is seen, as a study says, if the ischemia is of 1 hour, the patient presents with us with a deterioration of renal functions to an extent of 70 to 80%. But if we intervene immediately, we see complete recovery in majority of these cases, but by the end of few weeks. But if the duration of ischemia is 2 hours or more, the long-term recovery is only 30 to 50%, and majority of these patients sadly end up into being dialysis dependent if both the kidneys are involved. Now, what type of renal occlusion was it? Was it a gradual occlusion or acute occlusion? As acute arterial occlusions, arterial stenosis, arterial disease are involved. If there is a gradual occlusion, there is a collateral circulation which gets developed. And with majority of the areas, even in kidneys, though even there are end arteries, but the 80% of renal vascularized vessels are vascularity is independent of main renal artery, which per se is very important in maintaining the flow if there's a gradual renal occlusion. The collateral circulation commonly comes, as I told in the picture image, main renal artery only gives the inferior adrenal branch. So it can, the main renal artery, even if gets occluded, there can be a reversal flow for the inferior adrenal. There can be gonadal vessels, uretral, internal iliac, lumbar, intercostal or capsular arteries. Basically, all the arteries which are around the area, they can act as a collateral circulation in a case of gradual renal artery occlusion. And rarely even inferior mesenteric artery and its branches, they supply this. Also, the extra renal arteries, which can be the adventitial arteries or extra arteries which are present, in which is seen in 24 to 40%, 42% cases, they per se also help in salvaging the renal function in a case of gradual renal occlusion or even in acute renal occlusion, because then these are the arteries which become dominant and take care of the maximum renal vascularities. So this is an image in which basically the collateral circulation has been divided into 4 different complex: superior capsular complex, lateral capsular complex, inferior, periureteric complex, and peripelvic complex. So as I told you, the different named arteries, these are the arteries which are supplying, and they act as a collateral circulation, and hence they salvage the renal functions even in a case of arterial occlusion. So what do we find in a Doppler imaging? Doppler ultrasound is, even when there is a main renal artery occlusion and we see a good renal vein flow, so this means there is a collateral arterial flow which is taking care of the renal vascularity. Now going to the renal vein thrombosis, it can be primarily or it can be associated with IVC thrombosis. In a case of renal vein thrombosis, which is rapid, there is congestion and edema because there is no outflow. Because of congestion and edema, there is pain. Pain is because of the distension of the renal capsule. And because of the congestion and increased pressure, there is a hemorrhagic infarction which can take place. One thing which is very important, as also seen in other cases, is acute renal venous thrombosis is more severe than acute renal arterial thrombosis. Because in a case of renal venous thrombosis, there is no outflow vein. So even if there's a gradual occlusion in a case of arterial, there is outflow which is still persistent. So collateral circulation can pick up. So now, how do acute renal ischemia present? In a case of acute renal ischemia, sadly, the patient presents to us with non-specific signs and symptoms. And if we just look to the signs and symptoms written in the gray, the patient presents to us with back pain or an abdominal pain, dyspnea, nausea, vomiting, hematuria, anuria, or hypertension. Per se, all these symptoms are also associated with renal colic. So the first thing which is ruled out is renal colic, and hence a NCCT is done. So in a case when all these specific, non-specific symptoms are seen in an emergency, but in NCCT, sadly, we don't see any calculi, and then high index of suspicion needs to be there for renal ischemia. Hence, we proceed to CT angio. Per se, because of the acute renal ischemia, though it is very dreadful, but the presentation is very delayed. That is more than 24 hours in general. As per the studies, they say that the patient who with the onset of disease, onset symptoms to the presentation of the patient to emergency is nearly 30 to 32 hours. RVT, when occurs in neonates, there is a typical triad which is there. There's a flank mass, basically because of the edema and congestion. Gross hematuria because of the bleeding, because of increase, there's a hemorrhagic infarction which takes place. And because of the thrombosis per se, there is thrombocytopenia. Now, how do we diagnose? Basically, when the patient comes in emergency, the labs are there. So what we see in any acute pathology in the body, acute abdomen, there is leukocytosis which is seen. Also, there is increased LDH. We see microscopic or gross hematuria or even proteinuria. Raised D dimers as associated with any thrombosis. Eosinophilia is typically seen in these cases, and eosinophilia per se, the studies say that it is indicative of atheroembolism. Any atheroembolism, we see typically eosinophilia in many such patients. So it can indicate that there is an thromboembolic event in the presence of a chronically atherosclerotic disease in the patient. And surprisingly, mostly because of the presence of the opposite kidney, there is increased or more of the cases, there is normal renal creatinine. Now, when we go for CT angiography, now I will tell you about the benefits and the pros and cons of the investigations. CT angiography, it's widely available. It's a rapid investigation, but we are giving radiation to the patient. In a case when there is a deranged RFTs, we have to give contrast to the patient, though it is 80% sensitive. And when we do a CT angiography, we can also pick up the aortic and iliac anatomy. So in a case when there is an intervention being planned, so CT angiography also lets us know through the excess and how to proceed or how to plan an endovascular or even an open surgical procedure. Also, with the CT angiography, we typically in a case of emergency, we ask for arterial, venous and delayed phase. So when the venous phase is there, so it is diagnostic of renal thrombosis. Now, what do we see? There's a hypoattenuation because now the dye is not reaching that area because of either an embolus or it is an ischemia or hypoperfusion associated with a mass effect. Also, there's a cortical rim sign which is there. So what is happening is there's a circumferential functioning glomeruli which gets enhanced by the dye. but the area in this is only happening in the surrounding area because of the other glomerular arteries which are filling up, but that particular area, ischemia area, doesn't get filled up. So this is what we see. This is an example of CT angiography demonstrating bilateral renal infarcts. Typically seen, as we see, there's a patient at sudden onset bilateral flank pain with a history of atrial fibrillation. So it's an embolic episode and leads to renal artery embolism, and hence there is an ischemia, hence there are infarcts which are seen. So they are bilateral wedge-shaped infarcts, hypotense lesions, which are consistent with embolic renal infarcts. Also, on color duplex imaging, I will discuss with the duplex ultrasound after some time. Second is MR angiography. It is highly sensitive. The most important thing is we can pick up the anatomic plus physiological assessment can be done in a case of MR angiography. Plus, the CT angiography is majorly, it can tell us about the main renal or the primary and the secondary segmental branches. But for an evaluation of renal segmental arteries and even an intraparenchymal disease, MR angiography is superior to CT angiography. And plus, this is more superior, especially when the contrast studies are contraindicated. But they are time consuming, extensive image post-processing time is required, and there is limited availability of MR angiography. But it is diagnostic, and it is basically the investigation of choice when a chronic renal artery occlusive disease is being looked for or is being evaluated. Coming to ultrasound, the sensitivity is low. It is operator dependent. It usually only picks up large infarcts. It has actually been seen in the studies, even in the retrospective studies, that even in case when the ultrasound was done, only out of 32 cases, there were only 4 to 6 cases in which the actual infarct was picked up by an ultrasonography. Plus, ultrasound, intra-abdominal ultrasound, the main problem is if the patient is obese or there is a bowel gas which is present, it makes it difficult for an ultrasonography to ultrasonography diagnose the disease. But it is widely available, easily done, and ideally it is also seen in all the ER rooms right now. But what do we actually see in a Doppler imaging is a wedge-shaped hypoechoic lesion because of the infarct with absent blood flows, obviously. And renal vein thrombosis, we see edema and congestion of the kidneys. So I'm just taking you back to the Doppler image. This is a renal infarction, and as we do a color Doppler scan, there is arterial embolism is being diagnosed because there's a wedge-shaped hypoechoic area and there is absence of blood flow as indicated in between the 5 arrows which are shown there. And in a case of renal vein thrombosis, we see congestion and edema, and typically edema and congestion is seen. There is there is infarction also seen in renal vein thrombosis. Typically, the kidneys are enlarged in the absence of any distal ureteric or pelvic obstruction. There is absence of any hydroureteronephrosis in these cases, just the renal edema is present. Then coming to nuclear renal scans, these are most sensitive. 97% sensitivity is there. Basically, there is a DTP and DMS scan in which basically we can pick up the structure and functional capacity of the kidney. It tells there is marked decreased renal blood flow, and it also tells, and then in the presence of preserved kidney size. This is the feature of renal artery ischemia in nuclear renal scans. So just to brief you out again, in the case of renal artery ischemia in a presentation, usually they are confused because there is a non-specific presentation with, and they're confused with a renal colic. So quickly a NCCT scan is done. If there is absence of stones, we proceed to a CT angiography. So majorly it is CT angiography which is more commonly performed and in which the renal artery infarcts are picked up. Now coming to the particular pathologies. So renal artery embolism, it is uncommon to begin with. More commonly, renal artery branches are involved. So it is distal branches which are involved than main renal artery. Now there is a new new entity which is cholesterol crystal embolization. In a case of atherosclerosis, obviously there are cholesterol debris which is present in the arteries, commonly seen in atherosclerotic artery, which cause a thromboembolic event in which the cholesterol debris go into multiple small cause multiple small renal emboli. Commonly, as in atherosclerosis, the main risk factors are male, hypertension, and atherosclerosis. Also, in a case when we are doing arterial catheterization, we are doing particularly selective renal angiography, or we are doing an intervention for an aorta or renal artery per se. And in a diseased vessel, the cholesterol debris can get dislodged and cause a thromboembolism and lead to cholesterol crystal embolization. But sadly, when a CCE is the cholesterol crystal embolization occurs and there is a renal emboli and there is a renal infarct, 30% of these patients end up into a state of dialysis by 2 years, and it is also associated with more mortality. So this is now few images which are there. Contrast angiogram demonstrating left main renal artery occlusion. There is abrupt cutoff which is seen in the left side, as you can see, and the pathology was an atrial fibrillation, and so the thromboembolic event was there. In the second, in this case, this is a renal artery thrombosis. In again, this case is a cardiac tumor embolus, which is there. Yes, selective renal angiography has been done, and we have seen the filling defects which are there. And as you see, there are segmental filling defects. Only the lower half of the distal vessels are being seen. They are enhanced on after diet, not the upper half. Diagnostic of renal artery embolism. So when there are cases of renal artery embolism, the treatment, any embolism, particularly to begin with, we have to anticoagulate. Now, the most important thing is not particularly why we are doing anticoagulation in these patients is not particularly for the primary treatment, but it is because of prevention of local propagation of renal artery thrombus, so that the thrombus or embolic event should not further cause main damage. We should still preserve the maximum renal functions. It should not be a progressive disease. Also, most of the causes, as I discussed, renal artery embolism, when there is a cardiac pathology which is there, the distal source is there. In such cases, additional embolic events can be prevented by anticoagulation, by LMWH, like heparin. Now, for us, as I told, as we discussed the different causes, evaluation of embolic source is very important, because end of the day, the definitive management is when we take care of the source and not particularly the after effect of it. And it also decreases the risk of repeat embolism, because if there is fire in the room and the cause of fire is not treated, then even if we keep on preventing the fires, but there can be further damage because the source of the fire is still there. So we have to take care of it on the side by side. So basic 2D echo in case of renal artery ischemia, renal artery in which the renal infarcts are seen, we can find out that the embolic source was in the heart, and we can work up for it. Also, what we have seen is when a case of renal artery embolism, there is 20% of cases, that 1 out of 5 cases, that there is a history of previous thromboembolism. So this also emphasizes that why there is evaluation of embolic source is very important. Now, coming to the third thing, that is revascularization. When do we do it? As in REDS, bilateral embolism deems revascularization very much necessary. Acute ischemia, or in a case of acute ischemia, when there is salvageable renal function, when we can further salvage the renal function, patient is hemodynamically stable, then we can go for revascularization, because end of the day, if a good revascularization has been done, embolectomy has been done, then there is maximum chances of renal salvage. Though the improvement of renal functions, majority of these patients still go into acute kidney injury, but there is recovery in maximum cases seen after weeks of follow-up. Rest anticoagulation alone can take care. Only all these two indications are there in which revascularization is deemed necessary. Now, when do we do endovascular interventions? So, as the advent catheter-directed thrombolysis or pharmacomechanical thromboaspiration or thrombectomies are performed, so we can take out the thrombus and hence we can decrease the thrombus load and hence revascularize the distal vessels. In a case of arterial embolism, typically when it is involving the major renal artery or the renal artery bifurcation, not the major renal artery, the renal artery bifurcation or a distal segmental branch, in which, as I discussed in a case of open surgery, when it is involving distal branches or it is involving the renal parenchyma, it is an intraparenchymal disease. It is very difficult for to surgically repair these cases because then we need to either do a bench surgery or we need to basically do a autologous branched graft in which internal iliac or saphenous vein is picked up. But in those cases, with the primitive knowledge that there is the renal arteries are end arteries, if we increase the ischemia time, if there's prolonged surgery, prolonged ischemia, if there's longer time which is required for a revascularization, hence the surgery is not possible and hence it is not going to help and hence we can end up into nephrectomies on table. So endovascular procedures came into picture in a case when there was renal artery bifurcation involvement or a distal segmental branch which was causing acute renal ischemia. So what we do is aspiration thrombectomies, angioplasty or stunting. So angioplasty and stunting is done in a case when there is renal artery stenosis. There is diseased artery which is proximally placed. Distal to that there is an aneurysm, or distal to that there is stasis, and that becomes cause of thrombus, and hence there's an emboli. So we have to basically take care of the main source in which there is renal artery stenosis. We do angioplasty of this, and if required, if there's a persistent significant recoil in these cases, then we have to do stunting for these cases. So in this, there's a renal artery embolism which is seen as there is a typical lesion which is seen after selectively cannulating the renal artery per se. Typically, it is seen in the distal branches, though in this case, it's the main renal artery which is being involved, but it is also extending into the segmental arteries. So in this case, the distal left renal artery embolus was demonstrated initially, and then a catheter-directed thrombolysis CDT was done. And following the CDT, you can see that angiography, post-CDT angiography demonstrated almost complete recovery, almost complete enhancement after giving dye. Now, when to do and how to do surgical embolectomies. So surgical embolectomies are done in a renal artery embolism causing renal artery ischemia through midline or a flank incision. Renal artery exposure is done like in any other embolic event. Embolectomy is performed. Removal of thrombus is done using some fine forceps and Fogarty's. And then one thing which is more important is when we are intervening and we're doing an embolectomy, if the thrombus load is extending into the aortic lumen, then we have to take a suprarenal control of aorta. After taking the control, distal and the proximal control, we close the arteriotomy. Just after the arteriotomy closure, we have to do an intraoperative completion Doppler ultrasound. Though the mortality associated with any surgical intervention, open surgical intervention associated with the renal artery is very high, and it is 25%. That is why, as the advent of microcatheters, at the advent of coaxial catheter system, as the advent of more endovascular procedure and availability of endovascular cath labs, the treatment of choice now has either become the endovascular procedures per se, though systemic anticoagulation is the first and foremost thing which is supposed to be done, because it helps in prevention of further damage and control of the source of embolus. Coming to renal artery thrombosis, in which I told that the pre-existing renal artery is diseased, which is atherosclerotic, causing renal artery stenosis. Now, what are the high risk factors when there is a pre-existing atherosclerotic renal artery stenosis? Age more than 55 years, sudden dehydration or sudden hypotension. Because of sudden hypotension and sudden dehydration, there can be an acute thrombotic occlusion which can take place. and hence there is an acute renal ischemia. Risk factors for thrombosis are, otherwise the risk factor of thrombosis are hypertension, systolic BP being more than 160 mmHg, diabetes, mellitus, systemic disease promotes atherosclerosis, and if there's a high grade stenosis more than 60%, as I told you, mild stenosis or a severe stenosis will not produce turbulence, will not produce that Venturi phenomenon in which there is distal stasis and embolism and distal aneurysm which can form. Also, a case of thrombosis is seen when there is a spontaneous renal artery dissection, as I told, when there is atherosclerosis, there is an intimal disease. Because of this intimal disease, there can be an intimal flap, which is seen in a case of dissection. But commonly, these cases are also seen in a diseased vessel in youngs, or in surprisingly also their male to female incidence is same, though atherosclerosis is more commonly seen in males. So a spontaneous renal artery dissection, it is commonly seen in youngs in a diseased vessel. And diseased vessels are can be because of the congenital connective tissue disorders like FMDs, as I discussed earlier. Also, Ehlers-Danlos syndrome, in this collagen disorder. Cocaine use is commonly seen in which there is the weakening of the intima and hence intimal flaps. Cocaine addicts are basically having incidence of multiple dissections. Strain exercise can cause dissections, and iatrogenic injuries because of any of the interventions which are done for renal arteries per se. Now coming to treatment of renal artery thrombosis. Again, artery thrombosis, medical management, that is systemic anticoagulation, is very important because it prevents thrombus propagation, hence prevents further damage, and also it prevents to preserve the collateral flow. So in a case of renal artery thrombosis, we know that the artery is diseased, hence there is a gradual occlusive event, which is more of the cases which is mostly seen. So there is a collateral circulation which is there, and as we see, as I told you, 80% of collateral circulation can take care even if there is a main renal artery occlusion. So systemic anticoagulation is deemed very important and necessary in these cases again. Plus control of hypertension and assessment and management of intravascular volume status is very important, because as I told you, in a diseased vessel in atherosclerosis, if there is dehydration, decrease intravascular volume, then it can basically precipitate acute thrombosis of that atherosclerotic or diseased vessel. Assessment intravascular volume status can be easily done nowadays by CVP monitoring or even the monitoring of IVC diameter. Then endovascular procedures, again angioplasty plus minus stenting. Actually, angioplasty and stenting is more commonly done for a renal artery thrombosis in a diseased vessel because of the renal artery stenosis which is there. Thrombolysis can be done. Similarly, like CDT, mechanical thrombectomies can be done on, and aspiration thrombectomies are basically CDTs which are performed. Now, main renal artery involvement. Basically, when the main renal artery is involved, in which there is renal artery stenosis, per se, we can perform endovascular procedures easily, and hence we can perform angioplasty, and plus minus stenting can be done for the main event. Plus, if the distal branches are involved, then CDT becomes the main choice of the main endovascular procedure which is done for these cases, because their thrombolysis, when there is a specific catheter directed thrombolysis being done, it thrombolyzes the distal branches also. Also, in a case of main renal artery thrombosis, if a CDT can be done in those cases also, per se, the short CDTs are done in which we can give a short time duration thrombolytic agents like actiplase or urofragments, and then we can immediately go for thromboaspirations using catheters. Systemic thrombolysis is done when there is acute bilateral occlusion. Initially, systemic thrombolysis was done in even on the unilateral side, but now with advent of CDT, with the advent of catheter-directed thrombolysis, the systemic thrombolysis is only indicated when there is an acute bilateral occlusion in a diseased vessel. When do we how do we do, or when do we do an open surgery? Again, renal artery thrombectomy can be done. bypass is required in these cases because the per se the renal artery is diseased. So an arterectomy or an aortorenal bypass has to be done. Also, an extra anatomical bypass has to be done, like an hepatorenal or sphenorenal bypass on the right side, hepatorenal and sphenorenal on the left side, which can be required for a diseased vessel to basically maintain the flow distal to the diseased vessel. Though open surgeries, as already discussed in renal artery diseases, is time consuming and perioperative mortality is very high and it is an invasive procedure. But what are the indications of an open surgery is when there is high chances of renal salvage, that is there is less ischemia, and then there was a history that the baseline kidney function tests were normal, and there was an acute thrombosis of chronic stenosis with collateral. So hence we know that the collateral circulation is picked up. So the anticoagulation is taking care of the distal perfusion through the collateral circulation, but we can still take care of the diseased vessel, and hence we can intervene in these cases. Or when there is failed or contraindicated endovascular treatment, like in a case when all these problems are because of trauma, there is multiple intra-abdominal injuries which are there, and hence anticoagulation is not possible, or there is a contraindication to anticoagulation, or there is a complication of anticoagulation, and hence in to salvage the renal functions we have to do a open surgery. Lastly, my last topic, when there's a renal vein thrombosis, very rare, less than 1 in 1 million cases, uh, it has been observed that it is most commonly non-catheter related thrombosis in neonates is seen in renal vein. Though the most common causes, as discussed earlier, for a renal vein thrombosis are a hypercoagulable state in which malignancy tops the chart, nephrotic syndrome tops the chart for specifically for the renal pathologies. Also, iatrogenically, renal vein thrombosis is seen when there is an IVC filter which is being placed and which is blocked, and hence there is proximal propagation of the thrombus into the renal veins. Or there is a placement of central venous catheters, in which there is like whole catheters which have been placed, and hence there is extensive thrombus which can extend into the renal veins. Treatment, again, treatment of choice in a renal vein thrombosis is anticoagulation. Even in neonates, it is the treatment of choice. Now, firstly, when we start anticoagulation, the drugs of choice are LMWH right now. Not vitamin K antagonists are not there in not the first line choices right now because of the too much of interactions with other drugs, too much of dietary interaction. Renal vegetables have to divide it. Hence, there has been shift to low molecular weight heparins. But then, as per the cause, if it is a temporary or a modifiable cause in which, like, there is infection, hormone use, pregnancy, or immobilization was the cause of thrombosis, then we have to do the anticoagulation for a limited time period, for a period of like 3 to 6 months. But if the cause is idiopathic, or if there is a long-term disease which is involved, like malignancy or like inherited thrombophilias, then in these cases lifelong anticoagulation is deemed necessary. Again, thrombectomy and thrombolysis is done in a case when there is bilateral thrombosis, or when there is solitary kidney and there is thrombosis of that kidney itself. So we have to give maximum chance to preserve the renal functions. Or there is failure or complication of anticoagulation. Or when we are saying that in a case of renal vein thrombosis or any other renal arterial or venous pathologies causing a acute renal failure, or there is persistent severe symptoms even after anticoagulation or any other pathology. And if we are in a case of renal malignancy in which we see that renal artery thrombosis is seen, IVC thrombosis is seen, and the treatment of choice in those cases is debulking, that in such cases nephrectomy is done. Then we, along with the nephrectomy, we do the thrombectomies also. Thank you so much. Was an extensive topic, but I think I've covered each and everything. Thank you so much. Thank you, Tapis sir.